Hello everyone, happy Friday. Today we're going to continue our talk about movement disorders, and today we're going to learn about multiple system atrophy, or MSA. Now, there was an IG Live in the past with Brian Malari, and we talked about MSA. So if you want to know more about MSA from more like a PT perspective, I invite you to check that out. So today we're going to talk about multiple system atrophy. And if you haven't heard about MSA, here you go. So the first case was described by James Parkinson in 1817. So he started describing the first case in his essay called Essay on the Shaking Palsy. So this case had autonomic features, and that might have been the first case described of MSA. So MSA describes a syndrome that is characterized by Parkinsonism, dysautonomia, and some ataxia. Now, before it was called Shy-Drager syndrome. So this is how they used to call MSA. Now, MSA or Shy-Drager syndrome, which is, the name of the neurologist, Shy. They also added the component of olivopontocerebellar atrophy or striatonigral degeneration. Wow, such hard words to pronounce. So, now the term of Shy-Drager syndrome, and I really hope I'm pronouncing this correctly, it is still used in the literature, so you will see it every so often. I remember reading about Shy-Drager syndrome in my prep for MCS, but basically is MSA, right? But it's how they used to call it before. So now, back in 1960, Shy-Drager, the neurologist from University of Pennsylvania and Columbia University, drew this attention to this disorder and described two men that had symptomatic orthostatic hypotension, impotence, and bladder dysfunction. So these two men later developed Parkinsonian features, including gait disturbance and mild tremor, dysarthria, and just other dysautonomic features like constipation and incontinence. Now, as Shy-Drager continued to see these people, he realized some of these manifested some cerebellar signs, around 60% of the people with this disorder, and pyramidal signs. So if you don't remember what pyramidal signs mean, it just means just the pyramidal tract dysfunction, which can lead to the clinical presentation like spasticity, weakness, slowing of rapid alternating movement, hyperreflexia, and the Babinski sign. Okay, so now then later in 1995, this gentleman named Guddir Guja and his colleagues used some criteria to kind of determine, the diagnosis of MSA. And this was onset after 40 years, disease duration of less than 10 years, meaning that after the initial symptom, they would have, less than 10 years to live. Parkinsonian symptoms, poorly responsive to levodopa, autonomic failure, and the absence of family history of Parkinsonism, or no apraxia, no supranuclear ophthalmoplegia, and no lesions in the neuroimaging. So all these have to be checked in order for them to do the diagnosis of MSA. Now, this was back in 1995. They kept investigating these patients, and then they came up with a review of 188 patients, proven cases of MSA. So 24% of the patients had involvement in all four systems: And you might be wondering which systems were. Well, here they are. Parkinsonism. So we are talking about striatonigral degeneration. Cerebellar, so olivopontocerebellar atrophy. Corticospinal, and dysautonomia, so the autonomic nervous system. So those are the 4 systems, okay? So that's why it's called multiple system atrophy, okay? And then 18% had the combination of Parkinsonism, pyramidal, and autonomic. 11% had Parkinsonism, cerebellar, and autonomic. And other 11% had Parkinsonism and dysautonomia. Okay, so now here you're putting things together in your mind and thinking this is a condition that involves, you know, some Parkinsonism, maybe some ataxia sometimes, and for sure that dysautonomia. Okay, now let's talk about the features that they argue are not MSA. So if MSA, the age of onset was more than 75 years old, it's probably not MSA. Your typical Parkinson's resting tremor, probably not MSA. So MSA, as I was reading a little bit, you know, it lacks, most of the patients lack the tremor. They don't have the tremor, okay? If they have neuropathy or hallucinations or dementia, or like the white matter lesions in the imaging, it is not MSA. Now, we're going to move on to the clinical features. Okay, so now we've described this condition, this systems, diagnosis, what is not MSA. So MSA has been classified as multiple system atrophy P, if it's more with Parkinsonian symptoms, or MSA C, which is more cerebellar. So again, striatonigral degeneration or olivopontocerebellar atrophy. So now the predominant features for MSA are rigidity and hypokinesia. So this is how you're like, oh, that sounds like Parkinson's, right? So that's why a lot of these people, sometimes people confuse it with Parkinson's disease, which is not, right? The ones that really have the high specificity for MSA P, which is a Parkinsonian, are the early instability, rapid progression, abnormal posture, so like the PISA syndrome, or disproportionate anterior collis, okay, bulbar dysfunction, dysphonia, dysarthria, respiratory involvement, and emotional incontinence. So those are the ones that, if you have a combination of 2 out of the 6, most likely they have MSA P, which again, P is for the Parkinsonian, which is striatonigral degeneration. Okay, so now here is one of the cardinal signs of MSA, and that is autonomic dysfunction. So particularly orthostatic hypotension, urinary incontinence, or impotence. And these patients will develop this symptomatic orthostatic hypotension within 1 year. Now, usually they start with the symptom of impotence years before they are really showing any signs of MSA. That autonomic failure starts even before, years before, and sometimes it's even urinary disturbances before the orthostatic hypotension, because like personally, when I hear MSA, I think orthostatic hypotension, but please note that's not the only autonomic symptom, okay? So let's just keep that in mind. Autonomic dysfunction is essential for the diagnosis of MSA. So in many cases, like they have the orthostatic hypotension really, really severe. And it's hard, you know, because in therapy, we're changing positions very often. So now here in this video, I'm not going to talk about, you know, what do you do in therapy. Here I'm just introducing and bringing awareness of this condition. But again, I invite you to look at the IG Live with Brian Malari for you know, how he approached this patients in the clinic and how he worked with, you know, during PT sessions when they will be experiencing this symptomatic orthostatic hypotension. So then there's another thing, the cold hand sign, when they have cold, clammy, almost purplish hands. That's another characteristic feature. Sometimes they have the cold feet, okay? Severe obstructive sleep apnea with vocal cord paralysis and stridor, very particular in advanced MSA. And respiratory insufficiency might be also another presenting symptom of MSA. Okay, so as you see, this condition really stands out, that autonomic dysfunction compared to, you know, the PSP, which really stood out the ocular mobility as one of the cardinal signs. So you can start seeing how these are similar, but these are very different. And these are not Parkinson's disease, right? So we do see some autonomic features in Parkinson's disease, but this one, it's very particular that they're saying, you know, the impotence, the urinary incontinence, the orthostatic hypotension, the vocal cord paralysis later on, the respiratory insufficiency, you know, very, very particular things. So I really hope this helped you understand more MSA, and I will see you next time for our next movement disorder. Bye.